Namaste, Bitya. Anisha Kushro, Bitya. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue with the series of the respiratory system. And today we are going to discuss about bronchiectasis. Till now, we have covered a lot of topics, and I believe you must all have gone through the books and the notes and PPTs that I have uploaded on the portal, jvw.in. It is very essential to go through the book because a lot of topics and a lot of things that could be missed in this particular session that is covered by the books. So you have to go through the books, and it is very essential to prepare the notes from the books as well as from the e-notes that I have provided on the portal. Now, let's start with bronchiectasis. What is bronchiectasis? What is the etiopathogenesis? What are the various clinical features, investigations, and the management of bronchiectasis? So let's start with bronchiectasis now. Bronchiectasis is the irreversible airway dilatation that involves the lung in either a focal or diffuse manner. So what happens in bronchiectasis? It is the irreversible airway dilatation. There is dilatation of the airways and it is irreversible. It can be localized dilatation or it can be diffuse dilatation. The permanent dilatation and distortion of the bronchi. It is classically has been categorized as cylindrical or tubular, the most common type, the varicose and the cystic. So there are three types of airway dilatation that are commonly seen in the lungs. We have cylindrical, we have varicose, and we have cystic dilatation. So cylindrical or the tubular, cystic and varicose dilatation. There is also a pathological classification. Pathological means the changes that we are going to see in the lungs. So pathological classification is the same, the cylindrical, varicose, and the cystic vasodilatation. The pictures of these vasodilatation, different type of vasodilatation, I have given in the PPT that I have shown to, that I have updated on the portal. Now, what is the etiology of bronchiectasis? As we all know, bronchiectasis is the abnormal, irreversible abnormal dilatation of the lungs in local or diffuse manner. Now, etiology of bronchiectasis, it can be because of the infectious or non-infectious causes. So, bronchiectasis can be due to infectious cause or it can also be due to the non-infectious causes. Based on the level of spread or the degree of spread, it can be focal and it can be diffused. Focal, that is localized to a particular part, and diffuse, that is diffused or involving the whole of the lungs. Focal bronchiectasis. Focal bronchiectasis refers to the bronchiectatic changes in the localized area of the lungs. So we have bronchiectatic changes in the localized area of the lungs. And diffuse bronchiectasis, it is characterized by the widespread bronchiectatic changes, that is widespread dilatation throughout the lungs. Now we come to the focal bronchiectasis, in which there is only localized area of the lungs involved. Focal bronchiectasis is causing the obstruction by two types of factors, extrinsic factors and intrinsic factors. In the extrinsic factors, it is due to the compression by the adjacent lymphadenopathy or parenchymal tumor mass. So we have compression by the adjacent lymphadenopathy or parenchymal tumor mass. The intrinsic factors, it is due to the airway tumor or aspirational foreign body, a scarred stenotic airway or bronchial atresia from the congenital underdevelopment of the airway. So focal bronchiectasis, it is caused by the obstruction that is due to two factors, extrinsic factors and intrinsic factors. Extrinsic factors, it is due to compression by the adjacent lymphadenopathy or parenchymal tumor mass. And intrinsic factors are due to the airway tumor or aspirated foreign body, a scarred stenotic airway or bronchial atresia from the congenital underdevelopment of the airways. Now we come to the diffused bronchiectasis. Diffuse means in which there are a lot of changes. So focal was due to intrinsic factor and due to extrinsic factor. Whereas diffuse, it occurs from the underlying systemic or infectious disease process. So we have systemic or diffuse infectious disease process. There is involvement of the upper lung field. Upper lung field, it is more common in cystic fibrosis, and it is also observed in postprandial fibrosis. There is predominant involvement of the lower lung fields, and usually it has sources in the chronic recurrent aspiration. So we have chronic recurrent aspirations with end-stage fibrotic lung disease. So there is end-stage fibrotic lung disease or recurrent immunodeficiency associated infections. So there is predominant involvement of the lower lung field. It usually has a source in recurrent chronic infection and stage fibrotic lung disease or recurrent immunodeficiency associated infections. The mid-lung fields resulting from the infections by non-tuberculous Mycobacterium, NTM, mostly occurs in the Mycobacterium avium intracellular complex, that is MAC. Congenital causes of bronchiectasis with predominant mid-lung field involvement includes dyskinetic, immotility, ciliary syndrome, in many of the cases, the etiology of bronchiectasis is not clear. It is not determined. In many of the cases, the etiology of bronchiectasis is not determined, and it is known as idiopathic diseases. Now, what is the epidemiology? The epidemiology varies greatly with the underlying etiology. So the epidemiology, it varies with the underlying etiology. There is incidence of bronchiectasis with the increasing age. So there is incidence of bronchiectasis that is increases with the age. As the age increases, the chances for bronchiectasis increases. The incidence is high among the women than in men. So with age it increases, it is more in women. There is high incidence of malnutrition in certain areas and may predispose to immune dysfunction and development of the bronchiectasis. 25 to 50% of the patients with bronchiectasis have idiopathic disease. So epidemiology varies greatly with the etiology. The incidence of bronchiectasis increases with the age, and the incidence is higher among the women than in men. There is high incidence of malnutrition in certain areas and may predispose to immune dysfunction and development of bronchiectasis. 25 to 50% of the patients with bronchiectasis have idiopathic diseases. Now we come to the pathogenesis. What is pathogenesis and what are the different changes that are occurring in case of bronchiectasis? In the pathogenesis, there is vicious cycle hypothesis. Vicious cycle hypothesis, which states there is susceptibility to infection and poor mucociliary clearance. This results in microbiological colonization of the bronchial tree. So there is vicious cycle hypothesis, which states that susceptibility to infection and poor mucociliary clearance, it results in the microbiological colonization of the bronchial tree. And also has Pseudomonas aeruginosa that exhibits a particular propensity for colonizing damaged airways and evading host defense mechanism. There are classical studies which demonstrates small airway wall inflammation and larger airway wall destruction, as well as dilatation. There is classical studies that have demonstrated that the small airway inflammation and large airway wall destruction, as well as dilatation, with the loss of elastin, smooth muscles, and cartilage. So we have the loss of elastin, smooth muscles, and the cartilage. The ongoing inflammatory process in the smaller airway results in airflow obstruction. So there is inflammatory process and that is leading to airflow obstruction. There is destruction of the airway walls, dilatation and loss of elastin, smooth muscles and the cartilage. Bronchiectasis and emphysema have been observed in patients with alpha-1 antitrypsin deficiency. The mechanism for non-infectious bronchiectasis includes immune-mediated reactions that damage the bronchial wall. Example, those associated with systemic autoimmune condition such as Sjogren's syndrome and rheumatoid arthritis. We also have traction bronchiectasis. It refers to the dilated airway arising from the parenchymal distortion as a result of lung fibrosis. Example, post-radiation fibrosis or idiopathic pulmonary fibrosis. So, in the bronchiectasis and emphysema, the patients with alpha-1 antitrypsin deficiency, there is mechanism of non-infectious bronchiectasis, which include immune-mediated reactions that damage the bronchial wall. And traction bronchiectasis, it refers to dilated airways arising from the parenchymal distortion as a result of lung fibrosis. Now, what are the clinical features or the clinical manifestations with which a patient can come in case of bronchiectasis? There is persistent productive cough with ongoing production of thick tenacious sputum. So there is constant productive cough with the ongoing production of tenacious sputum. The physical findings often includes crackles or wheezes on the lungs auscultation. Some patient exhibits clubbing of the digits. So there is persistent cough with ongoing production of thick tenacious sputum. The physical findings includes crackles, wheezes on the lung auscultation, and some patients exhibit clubbing of the digits. There is also mild to moderate airflow obstruction that is often detected on pulmonary function test. In the pulmonary function test, we are going to observe mild to moderate airflow obstruction. Acute exacerbations are characterized by increased volume and purulence of the sputum production. Typical signs and symptoms of lung infections are present, such as fever, new infiltrates. These may not be present. So, new symptoms of lung infections like fever and new infiltrates may not be present. In the acute exacerbation, there is large amount of purulent sputum production. Now, approach to the patient. Whenever such patient is coming to us, how you are going to approach in case of bronchiectasis? The approach to the patient consists of eliciting the clinical history with chest imaging and workup to determine the underlying etiology. So we have to check for the clinical history, the chest imaging and workup for the underlying etiology. The bronchoscopy to exclude airway obstruction by the underlying mass or foreign body in the focal bronchiectasis, and then pulmonary function test have to be performed. Bacteriological and mycological examination of the sputum has to be done, and assessment of the ciliary function test should be done. So there is elicitation of the clinical history, chest imaging, and workup to determine the underlying etiology. Bronchoscopy to exclude airway obstruction by the underlying masses of foreign body in focal bronchiectasis. Pulmonary function test can be done. Bacteriological and mycological examination of the sputum has to be done, and assessment of the ciliary function. Now, diagnosis. How to diagnose a case of bronchiectasis? Persistent chronic cough and sputum production accompanied by consistent radiographic features. So there is persistent chronic cough and sputum. There is great cough and sputum that is accompanied by consistent radiographic features. Chest radiographs lack sensitivity, the presence of tram tracks. So this is the most important feature that you are going to see in case of bronchiectasis. That is tram track appearance. Tram means the tracks of the tram train that is usually you can see in Kolkata. So tram tracks appearance indicating dilated airways is consistent with the bronchiectasis. CT findings is more specific. The CT findings includes the airway dilatation and detected as parallel tram tracks or the signet ring sign. So we have two types of clinical features. One is tram tracks and the other one is the signet ring sign. A cross-sectional area of the airways with a diameter of at least 1.5 times that of adjacent vessels. There is lack of bronchial tapering with bronchial wall thickening or cyst emanating from the bronchial wall. So we have tram track appearance or the signet wall appearance. Now, how to manage a case of bronchiectasis? For management of the case of bronchiectasis, first of all, we have to control the active infection. Next is improvement in the secretion clearance. So first of all, we have to control the inactive infection. Then we have to do the improvement in the secretion clearance. Third is the bronchial hygiene that has to be taken care of. And fourth one, to decrease the microbial load within the airways and minimize the risk of repeated infections. So we have to control the active infection. Number one, we have to do the improvement in the secretion clearance. Number three, bronchial hygiene has to be maintained. Number four, to decrease in the morbid load within the airways and minimize the risk of repeated infections. Management includes antibiotic treatment, antibiotics targeting the causative and presumptive pathogen, that is Haemophilus influenzae and Pseudomonas aeruginosa. For Pseudomonas, oral ciprofloxacin or ceftazidime by intravenous injection or infusion may be required. Bronchial hygiene to enhance secretion clearance, hydration, mucolytic administrations, regular daily physiotherapy to assist the drainage of excessive bronchial secretions. So in the antibiotic treatment, we are giving presumptive or proper antibiotics like oral ciprofloxacin, ceftazidime, and intravenous injection. Bronchial hygiene includes secretion clearance, hydration of the mucolytic administration, regular daily physiotherapy to assist the drainage or excess bronchial secretions, and surgical treatment. Surgical treatment includes excision of the bronchiectatic areas that is only indicated in small portion of the cases. Next, we come to the prognosis. Now we come to the prognosis. The prognosis varies widely with the underlying etiology. And it may also be influenced by the frequency of exacerbations and specific pathogen involved. So in the prognosis, it is related to the varying etiology, and it may also be influenced by the frequency of exacerbations and specific pathogen involved. In the disease, if it is progressive and associated with ciliary dysfunction and cystic fibrosis, and eventually causes respiratory failure. The prognosis can be relatively good if the physiotherapy is performed regularly and antibiotics are used aggressively. Now, what are the different complications that could be seen in case of bronchiectasis? In the severe cases, the infectious bronchiectasis and recurrent infections with microbial resistance to antibiotics may develop. There is recurrent infection which can result in injury to superficial mucosal vessels with bleeding, and in severe cases, life-threatening hemoptysis. So in the severe cases, the infectious bronchiectasis and recurrent infections, microbial resistance to antibiotics may develop, and there is recurrent infection that can result into injury to superficial mucosal vessels with bleeding in severe cases with life-threatening hemoptysis. How to prevent bronchiectasis? Bronchiectasis is the reversal of the underlying immunodeficient state by administration of gamma globulin. This process can be prevented. And vaccination of the patient with chronic respiratory condition by influenza and pneumococcal vaccines. In the homeopathic management, there are certain medicines which include Amoncar, Entemtar, Balsamium peruvianum, calcarea carp, copavia, hippocell, and calibichrome, with creosote, medorinum, pertussin, phyllandrium aquaticum, phosphorus, sanguinarium nitricum, stannum, and tuberculinum, which can be given. I have given the indications, but in the PPT, but I'm just going to discuss few important of them. In the Balsamum peruvianum, there is bronchitis and phthisis with mucopurulent, thick, creamy expectoration. There are loud rales in the chest, very loose cough with hectic fever, and night sweats with irritating short cough and scanty expectoration. In the copavia, there is cough with profuse gray purulent expectoration with tickling in the larynx, trachea, and bronchi. The bronchial catarrh with profuse greenish offensive discharge. In the phyllandrium aquaticum, there is dyspnea and continuous cough early in the morning, cough with profuse and fetid expectoration that compels him to sit up. Sanguinarium nitricum, it has short hacking cough with expectoration of thick yellow sweetish mucus. Sternum metallicum, in which the mucus is expelled by forcible cough with violent dry cough in the evening until midnight. Cough is excited by laughing, singing, talking, worse lying on the right side, and during the day with copious greenish sweetish expectoration. So this was all about bronchiectasis. In the next lecture, we are going to start with a new topic, COPD. So this was all for today. This session is powered by digital version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. We will be meeting in the next lecture tomorrow. So I must say that you have to go through the portal and you have to check for the question that I have uploaded. You have to complete those questions as well. So this was all for today. Thank you very much. Have a good day.